I'm gonna owe you later, I guess. Thank you. All right, y'all. What are the signs and symptoms of poor perfusion in the body? Head to toe, go. Pale. Pale.
Blue nobody?
Cold extremities.
Cool extremities. Very good.
Weakness.
Hard to breathe.
Hard to breathe. Shortness of breath.
Baby clammy or no?
Could be.
Weakness.
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 Fatigue.
Fatigue.
You said fatigue.
Hypotension maybe?
Could somebody have chest pain related to not getting perfusion to their heart?
Yes.
That's called angina, right?
Yes.
They would not be able to tolerate activity, right?
Right.
Okay. So I want to make sure that you understand that, because we'll have a perfusion question come up on any test, and I get so upset if you miss it. It doesn't matter whether it's perfusion to my brain, which would be, I would have level of consciousness changes, right? Or perfusion to my gut, my bowel sounds would be hypoactive. Now, if I have poor perfusion to my heart, I have angina or chest pain. If I have poor perfusion to my legs,
Got poor circulation.
right, I have poor circulation. That's what poor perfusion means, right? They're cold. They may be something called mottled. Mottled means like this, a bluish, purplish, maroonish in some people, almost a lacy look, discoloration to their extremities. People who are dying and are losing their perfusion, especially white, pale people, their legs turn a horrible, ugly, nasty, purplish,
Bluish color.
bluish, reddish, nasty color. And we call that mottling. M-O-T-T-L-I-N-G. M-O-T-T-L-I-N-G. And you'll see that when you read in the book, and I just want you to understand what you are reading. And if you have never seen mottling, M-O-T-T-L-I-N-G, Google it. Okay, pictures of it. So that the first one that you see doesn't embarrass you or freak you out. And so when someone loses perfusion, it causes all kind of problems, doesn't it? Yeah. And if you completely lose it to your leg, can you lose your legs? Yes. And so that is an emergency when a person has arterial occlusion of the leg or complete arterial occlusion. Just like it's an emergency when someone is having a heart attack, because a heart attack means they have 80 to 90% blockage and sometimes 100% of a coronary artery serving a portion of their heart. And if we don't open it up quickly, it's going to die, just like their leg that we have to cut off. But we can't cut the heart out of their chest, can we? No. So we have to do a couple of different things to open the perfusion to that occluded vessel. So when I'm talking about overall perfusion, I'm talking about blood flowing through an artery, right? Okay. And why are those occluded? What are some of the reasons? Well, the main one is what? We talked about plaque, right? And that happens over time. There's another reason that our arteries become occluded quickly, and it is called spasm. Have you heard of people having spasms? You've had spasms in your muscles maybe before. You can have those spasms in your coronary arteries. And let me explain to you a patient that you may see. What about a patient who is shooting up crack cocaine? And there's nothing that makes the cath lab any madder than to be called out of their bed at night after working all day because somebody has been doing some crack cocaine, and they think, they come in, they have ST segment elevations all across their EKG. They called a STEMI alert. They have called the whole team, the cath lab team in. They're all ready and excited to save somebody's life. They go with wires up to their heart, and they see that their arteries are clean as a whistle. And what was happening is they were spasming because of what they have done to themselves. And so they're all kind of mad because they did it to themselves, but they get glad in the same pants they got mad in. And they will typically inject something like nitroglycerin to that area to make it open up if it's still happening. Or they'll do there's a few little techniques that they may do, but that is frustrating. So I just want to make sure that y'all understand that not all occlusions to the heart arteries are plaque. Okay? And also there's another real, to me it's like a moment, an aha moment for a lot of people. You know how men typically, not all, men typically have larger vessels?
Mm-hmm.
You know, have you ever started their IVs or whatever, they have larger vessels? Well, they have larger vessels in their heart as well than women. And we attribute that to why more women die a year after a heart attack than men do. Because if you think about it, just like it's hard to start an IV on somebody who has little vessels, it's also very hard to get a wire threaded up into the heart if their vessels are smaller and more tortuous. And women, their lesions in their heart, a lot of times are tricky, and they might be kind of outpouching, and they're harder to see, they're harder to stent. And so that is why. You know, we always say, oh, men, poor men, they're at risk more than women. Well, they're easier to fix, okay? But with that being said, understand, too, there's a big hormonal difference when we're looking at the heart with women. Premenopausal women are not as at risk as men. But as we age past, like you'll see when you're reading your hypertension section, when they get past 45, 46, 47, and our hormones start to decline, women are just as at risk, if not more at risk than men. So we start equalizing. And they're based on hormones is one of the reasons. So I just want to share that with you because I know a lot of times people think, well, I'm a woman, I'm not as at risk. I'm like, oh, but you're more likely to die if you have a heart attack a year later. So I just think it's important that you read that section and understand the true risk because that'll be the thing that you die of. The number one killer of all, women and men, is heart disease. All right. Now, back to this. This is the hardest part. This is the slide you got to know, okay? When we are teaching telemetry techs in the hospital, this is your process, and you can't skip a process. You can't skip a step, or you are going to mess up and miss something. So when we start looking at an EKG strip, we make sure first that they know how to read time, what the boxes mean, okay, and rate, and then we go into this. First thing we need to do is determine the heart rate. And if it's between 60 and 100, is that the inherent rate of the sinus node?
Yeah.
Yeah. Check. Then we look and we go, is it regular? And you go, what does that mean? Well, we look at the QRS complex. It's that bigger complex. And we look to see if they are equally spaced apart. So if you took a piece of paper, you should be able to mark a little hash mark at the top of the QRS and the one right next to it, and then take your paper and walk it across, and all of them should match if it's regular. Okay, we're going to look at it. I'll show you what I'm talking about. And then the next step, number 3 step, is what? Are P waves present? Are they all upright, round, and married to a QRS? Now look at here, we got to measure stuff. And I do not like to measure stuff. But we can cheat a little. I'm going to teach you how to cheat. We're going to measure the PR interval, and it should be between 0.12 and 0.20. Well, I just told you that one big box is what? 0.20. So if that PR interval, we'll look for one that starts close to a box. If it's within one box, we good. That's how I cheat. You got to watch that. And then the QRS, here's my other cheat. The duration of it, which means if we're talking duration, we're talking time. We're measuring it left to right, the QRS itself. And so here's Thomas Cooper cheese. Is it skinny or wide? Is it narrow or wide? If it's narrow or skinny, we good. Okay? Because that means it falls into sinus rhythm. So for a rhythm to be sinus rhythm, it has to, normal sinus rhythm, it has to fit every bit of this. So this is your recipe right here. This is how you can 100% say that that person is in normal sinus rhythm. They fit all this criteria. All right? We can't miss a step. Okay. So determining heart rate. What did we say we look between? 3 seconds. Y'all see the 3-second markers right here? And so we need to look at 6 seconds. So we need to take a pen and draw this one off because we're not going to count this one because it's not within that mark. Do y'all see that? Okay, so let's count QRSs. You ready? 1, 2, 3, 4, 5, 6, 7. 70. Is that between 60 and 100?
Yes.
Okay, what was our next thing we got to do?
Heart rhythm.
All right, is it regular or irregular? So,
Upright P waves.
all right, do we have, all right, is it regular, you guys? Are these equally spaced apart?
Yes.
Sorry.
Okay. It can be off just a tiny little box or two and it's still okay, okay? Y'all good?
Yeah.
Okay. Now what we gotta do?
Check the P waves.
Check the P waves. Are they round, upright, and kind of all look the same?
Yep.
Yeah. And so now, do y'all see this is a big box right here? And here's where the P starts, about right here. Going up, and it ends right here. Is that within this big box?
Yep.
Okay, so are we fitting all the criteria for normal sinus rhythm so
Yeah.
far? Okay, what about the QRS? Is it skinny?
Yep.
Yes.
Yeah, so if we were measuring it for real, then we would count little boxes. So that looks like 1, 2, 2.5. And what did you tell me one box is? 0.04 seconds times 2, about what? 0.08. Is that less than 0.12?
Yes.
Yep.
Are we good?
Yes.
Yeah.
Okay, cool. And so we would call this normal sinus rhythm rate of what? 70. And this is how they like to trick you at the hospital. They go, what's the ventricular rate? Well, we just counted QRSs, which means the ventricular rate, because QRS equals ventricular activity, correct? Okay, now they're going to say, well, what's the atrial rate? Well, what tells you atrial firing off?
The P wave.
The P wave. Well, duh, we
It's
got
still
a
gonna be
P for
70.
every QRS if it's sinus rhythm. So don't let anybody freak you out. If they ask you atrial rate, if it's sinus rhythm, it's the same as ventricular rate. Make sense? Kind of understanding why you needed to know what each complex means now? Okay. All right. So these are T waves, and they're not normal. So do you see how here's the P wave up top, then you have QRS, and what happened to the T?
It inverted. Then
It inverted. It inverted. That could mean, an inverted T could mean ischemia. So write that down. It also could mean hypokalemia. So you see where, looking at someone's EKG, we're like little detectives. Why is that happening? Why is that happening? And we'll see like inverted T waves after someone has heart surgery sometimes. Well, does it make sense to you that their myocardium could be a little ischemic? And after heart surgery, sometimes their potassium levels drop. So we're going to start looking at their O2 sat. We also have to look at their labs, all right, to kind of figure it out, what's going on. All right, look up here. This cracks me up because you see this on a dialysis floor. Look at the bottom. You see the P, QRS. Look at the T wave, how big. Y'all see how big that is? Do you remember what a big tinted T wave stands for? Hyperkalemia. Dialysis patients, if they go without dialysis, and some of them will, because y'all, that gets old, having to go somewhere Monday, Wednesday, and Friday, or Tuesday, Thursday, Saturday of all your life, and sit there for 4 hours and get dialysis. And so they'll skip it. And if your kidneys aren't functioning, you can't get rid of potassium. And so they'll get hospitalized because they go into heart failure because they can't get rid of the fluid either. You'll hook them up to telemetry, and the telemetry monitor will be going wild. And it'll say their heart rate's 200. The monitor is just a computer. And all it does, it counts waves, and it thinks that the biggest wave is the QRS. And so that's why we don't just let machines handle reading the telemetry. We got to have a real body looking at it going, their heart rate ain't 200. That dumb machine is counting the T wave. So do y'all see how that can confuse a machine? And so, okay, what I want you to know is that a peaked T wave equals hyperkalemia. So these T waves can tell us stuff sometimes. So what's an inverted T possibly mean? Two things. Good deal. All right, so let's see if you remember anything that I taught you about reading a strip. What's the first step? What's the rate?
60 to
So
100.
we need to look at 6 seconds. So I marked them for you in red here. So we're only counting the ones within our
80.
So it's 80. Okay, is that between 60 and 100?
Yes.
Okay. Is it regular, which means that the QRSs are equally spaced apart?
Yes.
Yes. Are there P rounds smooth upright in front of every QRS?
Yes.
Yes. And that tells you the impulse is coming from the what node? The sinus node. Okay. And is the PR interval between 0.12 and 0.20? Well, we got to look at one on a line. This one right here is on a line. I don't know if you can see it in the back, but
And
I'm
it fits in
telling
the
you,
big
it's
box.
within this big box. One big box is 0.20. So is that
Yes.
within those parameters? Is the QRS skinny?
Yep.
Yes. All right. So what do we have?
Normal sinus rhythm, 80 beats a minute.
80 beats a minute. And I put it on the slide on purpose so that if you go back and look at this later, then you'll know what the answers are, okay? So again, do you need to know this? It's on 2 slides. Yes. All right, now, sinus Brady. What's the only difference from sinus rhythm with sinus Brady?
There's going to be
The
less
rate.
QRSs
Yeah,
present.
less the rate. So it is everything that normal sinus rhythm is. It's coming from the same place, but the rate is less than what?
60.
60. I like these because they're easy on the test.
Yeah.
1, 2, 3, 4. What's the rate?
40.
40. All right. Now let's do we can't skip. So we know the rate. Now, are these equally spaced apart?
Yes.
Yes.
Is there a P for every QRS?
Yes.
Yes. All right, is the PR interval within one big box? Well, look at this last one. Yeah, it is. It's all right. And so, is the QRS skinny?
Mm-hmm.
Yeah. So, how would you interpret that?
Sinus bradycardia, 40 beats a minute.
All right. And so, this is telling you that it is everything that sinus rhythm is, but the rate is what?
Less than 60.
Now, how do we treat that? Because, see, this is a nursing thing. Yes. But before we jump and give medicines, there's, yes, assess your patient first. There are some people who are well-conditioned athletes. Their heart rate stays in the 40s, and they're fine, and they feel fine. And then you're going to get mad when you go to the hospital and you got these cardiac patients who are on all these meds, and you learned in school, you hold that beta blocker if their heart rate is 55, and then you get to the hospital and they go, you better give that woman her heart medicine. She stays 55. She's about 52, 54 all the time, and she needs it. And so you say to yourself, Ms. Cooper said, if they're perfusing their brain, if they're holding their blood pressure, they can have it. Okay? But on your test,
Hold it.
Hold it.
you better hold it. NCLEX too, okay? You got that? All right, so first thing we're going to do is we're going to go assess our patient. And we're going to look at their cardiac output, because if the cardiac output is okay, they're perfusing their brain, they're talking to you fine, their blood pressure's fine. You with me? Okay? They're not feeling fatigued and like they're going to pass out. A patient is symptomatic when the heart rate is very low or very high. How do they feel? Weak, dizzy, like they're going to pass out. Now, if the person has a 40 heart rate and they're not symptomatic, get their blood pressure. Are they holding their blood pressure? If they're holding their blood pressure, it means they're perfusing all their major organs. All right, so if there's a reason, let's say their heart rate was 40, they were symptomatic and dizzy, they had low cardiac output, then we got to figure out why. Why is this heart rate so low? Sometimes people don't tolerate their medicines. Sometimes we put you on a beta blocker, and you were in the 80s, and now you're in the 40s, and you can't hardly get up. Is that a good thing?
No.
Do we need to give them any more?
No.
Do we need to call somebody?
Yes.
Yeah.
Yes. So, do y'all see in blue it says remove the cause? If you know the cause, we need to remove it. Let me tell you a common cause with heart patients. Straining to have a bowel movement. They'll be in there, trying to get that turd out, and they're vagling, right? So they're causing the brakes to come on. Well, how can we remove that out of the equation? This is a real simple kind of thing for old people like me. You take stool softeners every day, so you don't have to do that. When y'all get old, you just wait. You're in for a treat. You're like, God, this used to not be a problem. Dang. Okay. So, are stool softeners important in the heart patient?
Yes.
So if you, and they won't know, men especially, my husband thinks that 30 minutes sitting on the toilet is normal. Oh no. I'm like, is your turd that hard to come out? He's like, that's not what I'm doing. I'm like, I don't want to know what you're doing. But anyway, for old people, sometimes it could be that they're struggling to have bowel movement, you guys. And if that's the case, and you know they have a cardiac history, what are you going to get the doctor to prescribe for them?
Stool softener.
Are stool softeners important?
Yes.
Is Miss Cooper just telling you this because she's weird? No. Okay. So remove the cause. So if the cause is that they're all blocked up, we might need to add a stool softener. Okay. And then if needed, I love that little pretty girl that keeps telling me atropine, and she is so right. We can give 0.5 if they're alive. Just saying. All right. And hopefully they are. Okay. That's all you need to know for level 2. All right. Let's go on the flip side. Sinus tachycardia. You ready? It's everything that sinus rhythm is except the rate's what?
Faster.
Fast. What is fast? Anything over what?
100.
So is 101 tachycardia?
Yes.
Yes. Oh, I'll laugh. There was some question somewhere, and I had somebody come all mad. It was just 101. How was that tachycardia? I said, is that over 100? She said, yeah. I said, that's right. Okay. All right, here's 6 seconds. How do we count rate? We look between the 3-second markers and find our 6. They're in pink here, okay? I counted them for you.
11.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 100. No, 11.
11.
I'll count it wrong. See, you gotta watch me. I cheat. Okay. So it's 110. Is that above 100?
Yes.
Okay. Is that tachycardia? If it's coming from the sinus node. How do we know it's coming from the sinus node?
P-wave.
P-wave. So is there one in front of every QRS?
Yes.
Okay. Is the PR interval within one big box?
Yep.
Is the QRS skinny?
Yes.
So this is sinus
Tachycardia.
tachycardia. Okay. So what causes sinus tachycardia? Exercise. That's why we don't do it. Just kidding. What else? Pain, anxiety, fever,
White coat syndrome.
white coat syndrome. Certain men that get close to me make me have sinus tachycardia.
Yep.
Just saying. All right. And it happens to y'all too. That's why you're giggling. Okay. And certain women, I don't know. It could be the, I don't know. But you know. Anyway. So it might be that they are hypovolemic, because if your patient's tank is getting low on volume, does your heart have to work harder?
Yes.
So it has to go faster. Now let me tell you, I get this question in the hospital all the time, and when we're doing EKG, they go, oh my God, I can't tell if it's sinus tach or if it's SVT. How do you know the difference? With sinus tach, it comes on gradually. It comes on gradually. So this person will be like 80 heart rate, then they start spiking a fever in the afternoons, right? Everybody's fever goes up in the afternoons. If you don't know, you should know. That's a normal variance. And so if they were sick and they had a fever and their fever spikes to 102 or 103, for every 1 degree that your temperature goes up, your heart beats 10 beats faster, by the way. And so that would be a sinus tachycardia thing. Sinus tach comes on gradually. And we treat the cause. So we don't jump to give meds for sinus tachycardia. We look to see what's going on as to what is the cause. So if it's fever, we give them Tylenol. If it is that they're dry, they're hypovolemic, we give them fluids. That makes sense?
Yeah.
If you're exercising and it's bothering you, get off the treadmill. You know what I'm saying? So that's how you treat it. You treat the cause. So how does the patient feel when their heart rate goes fast? They get short of breath or dyspneic. That's what that means, difficulty breathing. Shortness of breath, dizziness, palpitations. And if their heart cannot supply the oxygen needed because their arteries are narrowing, you put them on the treadmill and increase the demand, what's going to hurt? Their chest, if they can feel it. Okay? And if they can't, we're watching, if we're doing a stress test, we're watching their EKG. What segment might go down or up even if they can't feel it? ST segment. So that's why during a stress test we monitor the 12-lead EKG constantly. Okay? So we treat the cause of this. If we have to give them a medicine, if we have to, to slow their heart rate, we're going to give them a calcium channel blocker or a beta blocker. And that's only if we have to. All right, so here's one that you don't have to know. Everybody breathe. Because this just upsets everybody, even in the hospital. And I think it's funny. All right, this is a very normal variant that some people have. They have what's called a sinus dysrhythmia or a sinus arrhythmia. And it is everything that sinus rhythm is, except the rhythm is not regular. But there's a pattern to it. We see this sometimes in old people and kids as well. And in some people, it's related to them breathing in and out, the change in the pressure in their thorax. So it's everything sinus rhythm is except for this irregularity. This is not on your test, okay? So remember, the first step was the rate within the 6-second strips. We'll just pretend. 1, 2, 3, 4, 5, 6, 7, 8. If it's 80, is that between 60 and 100?
Yeah.
Yes. Is it regular? No. Because look here. And now look how wide this is.
Right.
Okay, so the person, is there a P wave with every QRS?
Yes.
And they all look the same. So we know that's coming from the sinus node or SA node. So here's the difference. They're breathing in, and it's fast. When they start breathing out, it gets
Stretches
slower.
out.
And then if you'll do calipers or if you'll mark 2 lines on a piece of paper, when you get to here,
It's
these
back
are going to
again.
match. There's a pattern to it. Okay? Do I care if you know this?
No.
Do I want you to know that people have this and it's no big deal at all? It is their normal, natural rhythm. And there's no reason to treat it unless it's brand new and something's causing it. Okay? All right. So this is another example of it, and you can see all of these are answered for you. This isn't on your test, so I'm not going to waste time. But the only thing that makes this different than normal sinus rhythm is the pattern to the irregularity. All right, so let's look and see if you know what you're doing yet. All right, what is the one on the top?
Tachycardia.
Okay, and how do you know that?
Because they're all the same, but it's fast.
All right, now you got to use all your checks for later. I want you to practice. It's that recipe. Remember those 2 slides? Okay. So what's the one in the middle?
Sinus rhythm.
Normal sinus rhythm.
Normal sinus, yeah.
Normal sinus rhythm, PR intervals within this big box, P's for every QRS. Okay. What about the one on the bottom?
Sinus bradycardia.
All right. If you can do that, you got your test conquered.
Wow.
So quit stressing out. All right, we've already talked about hyperlipidemia, lipids being fats floating around in blood, right? You good?
Yeah.
All right, you know how to talk to them about, if you don't know what triglycerides and all that stuff is, learn it. I've been talking about coronary artery disease and cracked plaque, haven't I? Okay, well this is your picture, and you see this good looking man? That's your main person we worry about. He's African American and he's older, but nowadays women are starting to equal them when they get older, remember? You need to read that. You'd be shocked at all the studies that are out. So decreased blood flow is what is going to start causing them to start having signs and symptoms. And decreased blood flow to what? The heart muscle itself. Remember that the heart muscle is stingy and it gets its blood supply first. So if it's starting to hurt, what about the other organs in the body?
They're
Oh,
starting
yeah.
to
All right.
confuse.
So you have to know this. What are the non-modifiable risk factors? The things we cannot change. That's what that means.
Okay.
I can't change the fact that my dad dropped dead of a heart attack when he was young. I can't change that. That's one of my risk factors. I can't change that. Now, what can I change about myself? I told you that my cholesterol, when I first checked it in my 20s, after I had gotten out as a nurse and got money to get insurance and went to the doctor, I won't lie, I'm where y'all are. I've been there. In my 20s, I thought, well, my cholesterol, I'm a woman. 400 and something. Can I change that?
Yes.
I can change my cholesterol. So I had to change my whole way of being. My gender, don't say yes, but yes, I guess you can nowadays. And we need to talk about that because that may be on your NCLEX that are starting to include that kind of stuff, transgender and lesbian, the gay lesbian group. There is now, we know from the studies out that they are at high risk for cardiac disease because they are typically heavier. They've linked it to weight. And so that's something new out there, just so you know. But for us, really, you cannot change your gender, okay? Family history, I can't change my family history, and I can't change my ethnic background. Those are the things you can't change, okay? Can you change your cholesterol?
Yes.
Okay. So here are the modifiable risk factors, things you can change. Modify it, you can modify it or change it. So can you change cholesterol? Yes. Can you stop smoking? It's hard, guys, for people. I never did it. I'm just glad. Because I like things. I know you do too. Hypertension, can we change that? Can we control it?
Yes.
Yes. Impaired glucose, can we treat diabetes and keep it under control? Yes. Some diabetics go, I don't think so, but yes, you can. Obesity is very difficult, but do we need to make small changes to improve that?
Yes.
Yes.
Excessive alcohol is not good, and this one right here really gets Americans, especially Southern Americans, and that's limited physical activity. I think we're all just lazy. And then, and I don't know if it's lazy, I think it's time. We're all so busy and stressed. Stress, you can modify it, they tell me. I haven't figured out how yet, but I'm working it. All right, so angina. We've been saying that the problem here is that we have an imbalance between supply and demand, don't we? And so at times, and this is not every person, the pain's going to radiate to the left arm. And usually if this is going to happen, the person is emotionally stressed or physically stressed. And that is why we do a stress test. That's how we can pick up things sometimes that are happening to people. They'll say, I had chest pain or I got real short of breath at home and nauseated. Your doctor orders a stress test. And hopefully he did lab on you to check and make sure that your troponin and CK&B weren't elevated. Because would we want to know that before we put somebody that we did a stress test?
Yes.
Yes. And because we know that physical exertion or stress is going to increase the oxygen demand, right?
Yes.
Yes. And if you have coronary arteries that are blocked off, can you supply the oxygen to the heart? No.
Nope.
No. Your pipes are all stopped up. So what does the word ischemia mean? And it's up here on the slide if you don't know. You need to know. Lack of oxygen. Now with angina, you only have a small percentage of blockage. You're still getting some oxygen to the muscle. The heart muscle is not dead yet. Okay? So ischemia on an EKG, where would you look? At the ST segment. And you would know if it is depressed. You with me? We pulling all this together? All right. With angina, it is relieved by, first thing you do to somebody is position them. So we want them to stop and rest because we're trying to decrease the demand on the heart. The next medicine we can give to try to dilate that artery so that more blood can go through it is nitro. Okay. Another med that we can do to try to knock platelets off our cracked plaque is aspirin. Okay? All right. This angina, you need to know this, it lasts less than 15 minutes. And it usually has few, not always, but usually it has few associated signs and symptoms. And here they are. And they look very familiar. They look just like somebody who's having an MI, don't they?
Mm-hmm.
Sorry.
What is retrosternal pain?
Retro behind the sternum.
Okay.
Behind the sternum. Some people will say their back hurts.
Oh.
They're having a heart attack and they're saying their back hurts.
Mm-hmm.
So I don't ever blow patients off when they start telling me they're hurting. I'm in there and I'm looking at them, seeing if they're perfusing their brain. Are they talking to me correctly? How does their color look? If they are very dark complected, you want to pull down their lip and look at their mucous membranes. You can even do their eye like this to look and see what the pinkness is, in their conjunctiva. Look in their eyes.
Yeah.
I mean, there are some patients, the color, their natural color. I've had some Indian patients that were almost like a dark gray.
Yeah.
And God, you look pale anyway, and they're really not. That's their natural color. So I'm looking at their nail beds and their mouth. So anyway, nurses, we struggle with, is this angina or is this a heart attack, right?
Yeah.
Because, y'all, it's gray. I want you to think about it like this. It's the same thing. It's the same problem. The coronary artery is occluding. In angina, we still have some blood flow, okay? It's just a warning sign. You got a problem. In MI, you're talking about 80, 90 to 100% blocked. And it cracks up and the platelets keep building up, and we have 100% occlusion, is the muscle going to die?
Yeah.
Yeah, so we're talking about the same thing in degrees.
Yeah.
So one can go to the other. So they may come in with just angina and they've been having that for a few weeks. By the time they hit the hospital, guess what we're having? A heart attack. So does that make sense? Mm-hmm. Okay, and that's why all the signs and symptoms are what? The same. And one of the key indicators is the time. If it's angina, it's less than 15 minutes. If it's an MI, it is 30 minutes or greater than 30 minutes. Just say greater than 30 minutes, make it easier for you.
Okay.
All right, we use a word, and you'll read it in the books, and you'll hear us talk about it in the hospital, acute coronary syndromes. And if you take ACLS, then we use that word a lot. And that's just a big umbrella term. And what it's talking about, just like I told you, there's not a lot of difference between unstable angina and MI, right? It's just the degree of perfusion that's happening. Because a heart attack or an MI occurs over time. It occurs over time. Usually the person was having symptoms that they've been ignoring for weeks, months, is occurring over time. Y'all good with that?
Mm-hmm.
All right, so it could be somebody who's presenting with unstable angina or an acute MI, and so we're thinking that plaque is going to crack or rupture, big word, and then they're going to have those platelets and a thrombus, which is a blood clot form, and vasoconstriction. You do not have to know this. It's in your book, and if you're real interested in it, please read it, but you don't have time. So later on in your reading, when you get to level 3, you can learn about what all the forms of unstable angina are, and they're all a little bit different. But you do not have to know that for what? Level 2. Did I tell you that?
Yes.
Okay. So sometimes people who have unstable angina, they're going to come in, we're going to hook them up, and they're going to have some ST changes on this 12 lead.
Mhm.
Does it make sense to you that they're going to be a little deficient of oxygen?
Mm-hmm.
So their ST segment, it should be up here, and where is it?
Group.
It's depressed. What does that patient need?
Oxygen.
Okay. Look at the T wave. What's wrong with it?
Upside down.
What could that mean? Ischemia. Could mean their potassium's low, but in this case, if they're telling you their chest hurts, what do you think it is? Oxygen. All right. Oh, one more thing. Make sure you see this. So they may have changes on their EKG, but guess what's not going to be elevated? And they're not going to have lab evidence because they don't have necrosis or tissue death yet. This is just unstable angina. Now, if this keeps going on, can they proceed into an MI?
Yes.
Yes. So that's why we keep people for 24 hours and we draw enzymes every 8 hours times 3. So if this continues on, are we right there to help them? Yes, and we do further testing, and that is why we do it.
Real quick, so what you're saying, go back, when they have the ST depression and
They can have
normal troponin and TK levels, if we check those, it's just ischemia. But it could prolong become an MI.
Because what's going to happen first is the part of the heart muscle that's not getting fed by the coronary artery that's supposed to feed it is becoming ischemic.
Yeah, it's starting to die.
It's starting to.
Okay.
It's not dead yet. So we can do what? Can we fix it?
Yes.
Yeah.
Yeah, absolutely. All right, so an MI is the most serious of the acute coronary syndromes. Remember, that's a big umbrella term. And this is where now we're completely deprived of oxygen, and what? The heart muscle's starting to do what? To die and to leak. So now you're going to see elevated cardiac enzymes like elevated troponin, elevated CKMB. Does that make sense?
Yes.
And if it's big enough and bad enough, you're going to see elevated what? ST segment. All right. Now, there's the big terms right here. Subendocardial transmural and all this stuff. Don't worry about that right now. Okay? We'll worry about that in level 3. All right. All right. All that's doing is explaining further in MI. Most of them are caused by thrombus formation, which is a blood clot. Okay? Because had the plaque remained stable and not cracked, would the platelets go be getting and trying to clump together? No. All right. And that is why we treat front line the way that we do. And so they're going to have all those associated signs or symptoms, and it's just according if they're a male, female, or an older adult. Not everybody presents the same, right? All right, with an MI, here's the dead part right here. You see it?
Mm-hmm.
The pain is unrelenting. So when you ask them to rest, when you put oxygen on them, you hook them to the monitor, you have an IV, you said, here, put some nitro under your tongue, and you did it 3 times, checking blood pressure and all that stuff we talked about. You had them chew an aspirin. They are still dying.
Yes.
They are still hurting. It is not helping, and they're looking at you like you're nuts. You give me an aspirin, and my chest hurts. You give me a nitro, and my chest hurts. Do something, because they think they're going to die. So we used to say Mona. Call Mona. But Mona's in the wrong order. We still call her. And Mona stood for morphine, oxygen, nitro, and aspirin. We say on a nasty morning, someone come in with chest pain. O is oxygen, A is aspirin, N is nitro, M is morphine. So actually morphine, we don't give people morphine until we know if the nitro and the aspirin are going to help. Because if it's angina, what might help them? Oxygen or just resting might help them. And then we're not going to progress to, giving them meds with side effects unless we really need to. And the reason the morphine really helps is it decreases pain, It decreases preload and afterload because it helps with vasodilation too. Okay? And so sometimes morphine works, sometimes it does not work. What works? Let me tell you, they come in dying in pain like this. We get them to the cath lab, we open them up, and they're joking around with us as soon as we open up their coronary artery. They come in about to die, they go out laughing. That is very rewarding, okay? All right. Do you have to know that 30 minutes for a heart attack? Greater than 30 minutes? Yes. Angina is less than 15. All right. So how much is the blood flow when they're starting to have a heart attack? Look how much it's reduced. And I've seen 100% blockages go to the cath lab in their coronary vessel. Y'all see that? And it's relieved, their pain is only relieved by opioids. You remember that's the class of medication that morphine is in. And these evolve over hours. So a lot of times these patients are at home having all these signs and symptoms, but they don't realize what's going on with them. And some of them will die, probably about more than 80% of them in this area die before they even make it to the hospital. And so we talked about STEMI and NSTEMI, right? And we talked about time as muscle. So the faster we can get that artery, coronary artery opened up, the better. And I just told you on a nasty morning, didn't I? Yeah. So that's how we treat people with chest pain. I say, oh my, and then it's on a nasty morning in that order. Oxygen, aspirin, nitro, and morphine. And if you don't like that, you can use Mona. All right, so anyway, why do we need a calm, quiet environment? Because your sympathetic nervous system goes wild when you are hurting, and we need to calm everything down. So you can't freak out, even if you want to. And so we talked about why aspirin. And if you're giving somebody nitro, is there a safety issue with giving nitro? We've discussed that. So again, we're trying to reperfuse the heart muscle, and that's why we're giving the antiplatelet medicine to try to make the platelets quit sticking together and get some perfusion to the heart. And then we're going to either have to send them to the cath lab, or if they're in Leaksville, they may get a thrombolytic to try to dissolve the clot. And then they need to still get to where? The hospital. Okay, y'all. Here is like some little posters that we did. I talked to you on the first day about stable angina, how people know it's predictable when they're going to have chest pain, and they'll just take nitro at home. They have like mild plaques, and so there's like just some good little posters to differentiate between stable angina and unstable. Just trying to help you out with your studying, okay? And then here's you another little helpful poster about what you need to know about MI. Y'all see this is in yellow and blue. And remember, I told you about older adults and females already. These are just study helpful posters. Heart failure. Talked about it on the first day. What do you need to know? The difference in left-sided and right-sided. If they have left-sided heart failure, they're going to have all respiratory signs and symptoms. And your priority is assessment of the lungs or respiratory system. And you know that heart failure is associated with hypertension and coronary artery disease. And if I have a heart attack and a portion of my heart dies, can it just come back? No. So those patients are going to have will have a heart failure. Okay. Now let me just say this, because somebody in here usually brings it up. As you age and as you exercise, like me and the good-looking guy in the back, we the only ones.
About that.
Then you build collateral circulation, which means we strengthen our little blood vessels in our hearts. This is why exercise is so important, you guys, is especially in older people. If your coronary arteries are occluding, your collateral vessels that you have strengthened and built will save you. Okay? So that's why I need you all to start exercising. All right. So when you're learning about heart failure, you're going to learn about all the compensatory mechanisms that your body does. And that's that renin, angiotensin, aldosterone system that kind of does us in, makes it worse. And so remember that BMP is released when your ventricles stretch, and BMP is the lab that goes with heart failure. Do you need to know that?
Yes.
Yes. Okay, there's your signs and symptoms of left and right sided heart failure. That's up here for you, all these helpful things. The worst, read on this part, the worst case of left-sided heart failure is called pulmonary edema. You need to know how to treat it. Sorry, I'm still spitting on y'all. You need to know how to treat pulmonary edema. First thing you're going to do, high Fowler's position, because we're trying to displace all of this fluid down to the venous system. And then, what are we going to give them? Oxygen. Monitor IV, oh my. And then we could give them some nitro to make their tank bigger. And if they're scared to death and their sympathetic nervous system is going wild, we can also give them some morphine to calm everything down, because it's also going to cause vasodilation. That make sense?
Yes.
Okay, so that's how you treat it. So your first priority, the first thing you do is to
High Fowler's.
high Fowler's, sit them up, position first. Okay? All right, it's in blue. You see this lady?
Yeah.
She couldn't. She was too weak to sit on the side of this, so guess what we did to her?
Folded her over the table.
Put her up. All right? All right, so we're going to give Lasix. Why? Why would we give Lasix fluid?
Pull the fluid off of the
We're
heart.
going to give them Lasix because we got to get the fluid out of their lungs. Make sense? Okay. And don't leave anybody having chest pain. Don't say, let me go run and get the blood pressure machine. You got holler, you stay with the patient.
Yeah.
Okay? All right, signs and symptoms. It's telling you how to treat it, in case you don't have me. Here's how we treat heart failure. What's the most reliable indicator of fluid balance? Weight. How much weight?
Over 2
2 pounds overnight, or 3 pounds in a week is what is too much for an adult. Y'all got me? You got to know that. So remember, diuretics can cause hypokalemia, and clients who have their kidneys don't work, they're at risk for hyperkalemia. All right. We don't push people who have an exacerbation of heart failure, remember? We don't push them. Because can they tolerate it? No. If they're in an exacerbation of heart failure, they need bed rest. If somebody has ordered IV fluids, do you think that's an error?
Yes.
Yes. All right. So, again, that'd be something you question. So there's your weight gain. What if they feel like they have a cold over 3 to 5 days? Is that something you need to report?
Yes.
Yeah. Okay. So read all these. These are your study notes for heart failure. It's in your book. Now, I've been talking about peripheral arterial disease the whole way. It's no more than angina in the leg. You need to know acute arterial occlusion. You need to know it. In that section of peripheral arterial disease, it's kind of like angina and MI. I may have arterial disease and have intermittent claudication, that where my legs cramp as I walk a certain distance. Remember that word? Look for that word in your book. You got to know it. Intermittent claudication. But as my blood flow to my leg gets worse, if it completely cuts off, we call that a complete arterial occlusion. That is an emergency. Just like a heart attack's an emergency, that was an emergency. Y'all with me?
Yes.
And you have to know the P's, your 5 or 6 P's, to recognize the complete arterial occlusion. You know what it is? Pain, pallor, poikilothermy, which is just coolness. Okay. What else? Paralysis, pulselessness, paresthesia, where it's numb or feels weird like pins are in it. You got to know those, because that's telling you, that's how you as the nurse know that they have lost all blood supply. Now in your book, you need to know the difference between how arterial ulcers look, which they're cookie cutter, and because they're not getting blood supply, they're pale pink. And they look like you took a cookie cutter to the edges. And then the venous ones are real irritated and jagged. They're real jagged. And the venous ones are located in a different location. The arterial ones, you'll have like necrotic little lesions on your toes, okay? And they're black and necrotic because they're not getting blood flow. And then your venous ones, they're getting blood down, but they can't get blood where?
Back up.
Back up. And nursing students are fabulous. They'll do this for A, for arterial, because when someone is not getting blood supply down their legs hurt if you bring them up. Does that make sense? They need their legs to be positioned either neutral or down to try to help get any blood down, okay? People with venous problems, you see my legs are up. If you got a problem getting the blood flow back to your heart, you need to teach those people to bring their legs up 4 to 5 times a day for 20 minutes. And these people are the people that have to wear the compression hose for 24 hours. Yeah, at least 23 out of 24 hours. That's not easy to do in South Mississippi at 110 degrees. So again, you need to read on that. How do you teach? How do you teach somebody who has arterial disease? What do you teach them? What are the risks? Either way, do they have a blood flow problem, whether it's blood flow going down or blood flow coming back up? They do. But we want them looking at their feet every day. We do not want them going barefooted. We do not want them using heating pads because they will want to because they think heat helps in circulation. But they don't have good feeling in their legs if they have arterial or venous. So what's going to happen safety-wise? Burn.
Too hot.
Now, in your book it says chronic venous insufficiency or venous insufficiency, and it's past blood clots and stuff. And I even wrote the page down because y'all worry me to death over not reading what I want you to read. Page 746 and 747 in your book is venous insufficiency. Okay, now you have pulses in your feet, don't you? You
Yes.
have a
Carotid. Jesus, in the car.
She said carotid.
Stop.
No. Wait a minute. You have your dorsalis pedis.
Thank you.
It's on the top.
It had the letters in it. Okay.
I'm with you, girl. I'm with you. I'm with you. It's Friday. You don't matter. You can say anything to me today. And then you have a posterior tibial pulse, right? Posterior tibial. I'm just going to tell you, if you read, you know, not everybody has a dorsalis pedis pulse. Naturally. Some people don't have one. Everybody should have a posterior tibial pulse. So which one do you think is priority if you're looking at arterial disease?
Posterior tibial.
And priority in somebody that you assume is not getting good perfusion to their legs would be to check their posterior tibial pulse. And where is that one located? Right here, behind your what? Ankle bone. Malleolus is what we call that in medical terms, just saying. All right. So, with venous disease, the problem's getting blood flow back up to the heart. You agree? And remember we talked on the first day that they're going to have a lot of edema and that they're going to need compression. Well, we have to check the circulation in their legs before we put compression on them, right? So before they do Una boots, which is like a compression bandage you'll read, and you may even have seen that in wound care or in some of your patients. Y'all seen the Una boots on people? If you haven't, it's Coban, you know the stuff after they draw blood that they wrap around your arm to hold pressure. That's what they use with an Una boot, and they do it from the toe up to the above the knee. And they have to make sure they start down right at the toes where they start, or otherwise you would have all that edema. Yeah, in your toes. So we have to squeeze it up. And so venous insufficiency, compression is what they need. Their wounds can never heal if they're constantly leaking fluid. Does that make sense? And so that's why they're placed in Una boots. And that's why after they heal, they have to have compression for the rest of their life, because there's no surgery to fix veins like that. There's no surgery. So they have a lifetime of trying to prevent wounds, because their wounds or sores are not going to heal because they're constantly leaking because of the high pressure in their veins, because their valves are not working. Does that make sense? So we worry about keeping their feet clean and dry and keeping them from getting infected. So venous disease, their legs need to go Arterial disease either need to go neutral or down because we're trying to get blood supply to them. Do you need to know about arterial disease and how to recognize those ulcers? Do you need to know how to recognize a venous ulcer? Yes, you need to know how we treat them. Now, arterial lesions is just like heart lesions. They can go in and stent the leg, just like they stent your heart. It's an artery, it's just in a different location. They can give certain medications to make red blood cells more flexible, such as what we call Trintol, or y'all call generic names, pentoxifylline. So you'll read that. You'll read what they do to treat those. Can you surgically treat peripheral arterial disease?
Yes.
Yes. Is there any surgical treatment for veins?
No.
Venous disease? No. Are you going to allow them to do heating pads?
No.
Are you going to allow them to walk barefooted?
No.
Do they need well-fitting shoes?
Yes.
Yes. Do they need to keep between their toes clean and dry?
Yes.
Yes. So I think I have explained that well enough that you would understand what you were reading. Now, hypovolemic shock, we cover in fluid electrolytes. What does that mean?
Too much volume.
Their volume is lost. How do you lose volume? Vomit, diarrhea, you bleed out. You bleed out.
Diuresis.
Okay, diuresis, you gave them too much. They had dialysis, you sucked them too dry. Y'all understand there's a volume problem.
Yes.
Well, how we recognize it's occurring is we look at vital signs a lot, don't we?
Yeah.
So what we notice about their heart rate is it goes, so how we recognize hypovolemic shock early is tachycardia. Okay? Tachycardia. Okay, so don't forget that. Use this PowerPoint as your what? Study guide. Get into your book in these areas only, the ones I covered in this classroom and that are on your objectives. Know the meds I have drilled into you. Know Lenoxin as well. You know, how do you know someone's Lenoxic toxic? How you like that? All right. Anyway, those kind of things. I have told y'all everything that you need to know. I have explained everything in a way. I can't learn it for you, but I can help you because I know how difficult this can be to read it on your own and understand it. But I can't learn it for you. And as my mother says, if you can do it, they sure can do it. So, anyway, I have faith in all of you. And if you are reading something that you do not understand, you can ask me. You can email me. I'm in the hall all the time. I'm very approachable. So I want you to learn. Now, you may read something. Remember I told you they have to check the circulation in your legs before you put compression on them? In the hospital, they routinely do something called an ABI, an ankle brachial index. And that is what we do to check somebody's circulation in their leg in the hospital. It's real easy. It's not invasive. We just take not the nurse, but they'll send them and they'll do a blood pressure in their arm, and then they'll do it in their leg, and then they divide the two to get what their, you'll read that. But that's the test that I was telling you about, that they check. They have to check first. You'll read it in that section.
Or the carotid.
All right. Questions? Do you know what's on your test?
Don't confuse yourself.
Not all right.
The worst part, did I help you alleviate your fears over the worst part? One of my best students in level 3, one of them, was in here yesterday. And she said, Miss Cooper, the problem with level 2 is you made it seem easy, so I relaxed and I didn't really read in that book good. She said, she told whoever was in here, you better study 3 times as much as you think you need to, because I bombed that cardiac section. Bombing for her, though, you guys, was like 78. I mean,
Yeah.
she was like, you know. So don't take that she bombed it. But in nursing school, you've got to learn it the way you can learn it. So if you don't understand the way I'm saying something, GTS, there's all kinds of little videos and stuff. Or ask me. Stop me in the hall. No question is too simple for me. I put nitro in my eye. Come on. I mean, I'm sure I have done it, is what I'm trying to tell you.
So they check your carotid.
Check carotid. But anyway, that is important. And so in church,
Not at the
I go
same
to
time.
church every Sunday with a bunch of old people. And I swear one of them falls out every couple of Sundays. And we laugh because at my church you may think somebody's doing you an amen. No, we checking somebody's carotid fall. And so that's why I thought it was so funny when she said check their carotid. I was like, do you go to church with me? But anyway, I have enjoyed y'all so much. And Miss Jane has been at the store like 3 times, and I won't let her come in. She's that sweet. She's here to help you with skills. They had some extra time, and she wants to show you your clinical skills. What do y'all have? O2? How to apply O2 on somebody?
Yeah.
So the main thing with oxygen is making sure that you don't stick it on the patient before you turn it up. You turn it on and check
Yeah.
before you stick it in their nose. Make sure that the prongs are going down, not up. Laugh if you want to. They put lips on the darn oxygen tubing, so people like me make sure they get it right. Their little lip on the oxygen tubing goes to the lip. Laugh if you want to. I told them they not
We're holding you hostage again?
Yeah, I am.
Yes.
Yeah, I like it. I hadn't let them pee either.
Well, she needs to send her stuff.
Okay, good. Y'all can pee while she said that.
I thought she just forgot.
We both on it today. I'm telling you. Because that smooth went the opposite way I needed to go.
You know what's so crazy? It's like in class. Remember last semester I was saying some dumb
Oh no,
shit,
girl, that stuff
but on the
gives me
test I
hyper.
did well. No, I might have some lead. Let me check.
Do you take any medicine?
I don't know, but I gotta move around because, yeah. Oh, it's killing me.
I'm coming. I see.
I love reading the chapters and then listening to the lectures. Like that's what really helps me. It's the greatest.
Like, it's bad, but it's not like, yeah, that's what it hurts.
No.
And I'm about ready to kill over myself.
When I get into it, then I'm fine. In bed is fine. I'm just worried that I'm gonna like keel over going for a walk. And he's like, look. He's like, if you have an issue.
I've been known to stay in 6 hours.
And she goes, he asked me, he's like, what's the longest it's ever lasted? I'm like, the shaking is terrifying. No, it's just sitting in your chest doing
I
that.
just remember when I did, when it happened to me, I haven't been able to drive. I got here.
Well, 4:30.
I had right here. No, the test would have to be I remember I was teaching LPS one summer when I first got back. delay on the show, so I couldn't go home. And my mother was engaged. We couldn't get it. I had to go drink a bunch of.
But you still gotta do what you gotta do.
So I was drinking water and no salt and got it back up. But I had to lay on the floor for a while and I was like, and so, but I didn't miss nothing.
Last summer, I had that.
Well, my brother does it too. I had a brother, my dad died and we had him. My brother also, his first off the same time. And my brother used to go to Georgia Kansas so much, we'd laugh. Because I was like, I think he was thinking hard, he kind of quit. And, but, you know what I mean? And so we're both getting older and he's supposed to be trying. But he stopped doing it, so that's pretty good.
But it's really not.
Text me.
Why would y'all walk this through?
No kidding.
I literally said enjoy the rain.
I just feel the shit. It's like snappy.
Oh, yeah.
I feel that. Never actually happened.
We may toss our accumulation of snacks.
You're saying for that.
We have to eat like once or twice an hour. It's like, y'all made me want a snack. I do it at home, like as well. Up there, I was like, snack is there. That is our thing. So I felt like if they have
Did you have any questions?
Yeah.
Everything that we pack is a shared item. Also, everything else is. I do really.
You think you got to, but you don't.
No, I definitely do. I definitely do. Anyways, let's see what other snacks we have to graze on.
We have no other snacks to graze on besides that turkey.
What's on that? There's some raisins in there.
That's dried blueberries.
I love dried raisins.
It's not raisins, it's dried blueberries.
I love raisins.
I just want some chips with water soda.
Let's go get some chips.
Can we?
Yeah.
What time do we start? You're supposed to already have started.
Oh.
I need some water. I need to get us out of here. We got water. You want to? Will you give her an extra bottle of water?
Do you want to pack that? But it ain't that important. Can you give her a water, baby?
She's needy. Please. See, she said please. You're welcome.
Oh.
Yeah.
It's not me, but it's her.
It's dried blueberries. Yeah. Like what? Dried blueberries. Plant blueberry raisin. So nutritious. Great. Bless you.
When it's all green.
Hydrate them?
When you sneeze, when you sneeze, did you have your life?
Thank God every day when he lets me get in my tent on if I have to go.
So if it's the press, even if I have to go, I can just like it's so excited I sneeze out of sauce. And I'm like, what did that do? I got the Is that also hypothyroid? Where did all the meat go? I don't know.